I'm really honored to welcome you all to this session of Let Us Know All About Infective Uveitis. As we all know, infective uveitis is emerging as a leading cause of blindness these days in both immunocompetent as well as immunocompromised patients. There is an increase in number of cases of infectious uveitis noticed due to the use of immunosuppressants in patients suffering from autoimmune disease. So ophthalmologists should be aware of the commonest clinical presentation and treatment given for this condition. So welcome all. And our first talk will be by Dr. Risha, Senior Consultant Medical Retina and Uvea, and ma'am will be speaking on approach to infective anterior uveitis.
Good morning. Thank you, Neetu. So I'll be talking about approach to infective anterior uveitis. Why identification of an infective etiology is important? Because prompt diagnosis and prompt treatment with anti-infective therapy is very important. Missing an infective etiology starting on steroids or immunosuppressive therapy can exacerbate an underlying infection, leading to blindness and even death of the patient. So the major objectives of treating an infective uveitis is alleviate the symptoms and signs, control the infectious process, and prevent damage due to inflammation, and prevent recurrences, and last, rehabilitate the vision. Now I'll show you one case of granulomatous anterior uveitis. On examination, IOP was found to be high. So we think about viral etiology. Most likely it will be like viral anterior uveitis with high IOP. On seeing the fundus, see nasal to retina, there is a retinitis patch with vasculitis, ciliariasis vasculitis. So what it is? It's a toxoplasmosis, toxoretinochoroiditis related anterior uveitis, can present as granulomatous uveitis with raised IOP. So proper ocular examination is very important. Don't label a case as anterior uveitis unless you see a normal fundus. Again, another case of anterior uveitis with pigmented cells and high IOP. See what is there in fundus, 360-degree retinitis lesion. It's a case of ARN. Here, the timely diagnosis could save the vision of the patient. Yet another patient post-COVID presented with corneal edema and uveitis. So that was a case of viral keratouveitis due to herpes simplex virus seen most commonly in post-COVID patients. The commonest cause of anterior uveitis due to infection is herpetic uveitis, usually present as pain and redness, circumscribed corneal edema with fine pigmented capes posterior to that corneal edema and with reduced corneal sensation. AC reaction can be mild to moderate with or without posterior synec, IOP usually raised. Diagnosis is mainly clinical. Now coming to varicella zoster associated viral uveitis. The viral uveitis etiologies are HSV1, varicella zoster and CMV. The clinical manifestations overlap to a certain extent among three etiologies, but usually HSV is the commonest cause of viral anterior uveitis. Varicella zoster is not as common as HSV, but it presents with a severe uveitis. More pigmented capes, more chance of IOP rise, and initially with a moth-eaten appearance of iris, can see in the first picture, but later present with sectoral iris atrophy, typically described as triangular sector with base towards the pupillary margin. And the extent of iris atrophy depends upon the viral load in the anterior chamber. It can be granulomatous and non-granulomatous uveitis with raised IOP and iris atrophy. The diagnosis of viral keratouveitis is often clinical, but we can confirm the diagnosis by doing a PCR test for HSV, VZV, and CMV. The treatment is topical steroids, topical anti-glaucoma medicines with systemic antivirals for long term. Now I'll show a case of hypopyon uveitis. This patient was post-op, presented with sudden onset hypopyon uveitis. See, there are some yellow exudates in the pupillary margin, looks like infective etiology, and IC tap showed PCR positive for U bacterium. So that was a post-op endophthalmitis, anterior uveitis. See, there are another two hypopyon uveitis. Is it the same? In the first picture, circumcorneal congestion is there, hypopyon is there, but see the exudates in the pupillary margin is not like yellowish in the previous case. It's more of fibrinous membrane. So again, patient gave similar episodes in the both eyes before. Treatment with the topical steroids also before. So that was a case of HLA-B27 associated anterior uveitis with hypopyon. In the second case, again presented with a hypopyon, C. fundus, there is disc edema, retinitis lesions, and vasculitis. So that was a hypopyon uveitis associated with Behçet. Now coming to the other major cause for anterior uveitis is tuberculosis. Usually present as granulomatous. It can present as non-granulomatous uveitis also with iris busaka or copy nodules and posterior synechiae. Fundus choroidal lesions may or may not be there. The key features of TB anterior uveitis is granulomatous or non-granulomatous uveitis, broad-based anterior synechiae. See, this is a picture of broad-based anterior synechiae with ankle or iris granulomas. The diagnosis of tuberculosis is mainly MANTO and radiological investigations and quantiferon TB gold test. And management is based on Coates trial. The presence, the tests like PPD, IGRA, and radiology depends upon whether patient is coming from endemic or non-endemic area. And ATT include HRZD for 2 months and HRE for 6 months in a case of anterior uveitis. See, I'll show you 3 more cases of granulomatous anterior uveitis. The first one without broad-based anterior synechiae, only focal synechiae that released immediately with cycloplegics. That was a case of sarcoid uveitis. And second with sunset glow fundus, and third one with small cell carcinoma lung. Secondaries. HIV can have various presentations depending upon the immune status of the patient. See, this patient presented with anterior uveitis post rifabutin treatment. So that was a drug-induced anterior uveitis. Again, anterior uveitis with a cyst in the anterior chamber. It was cysticercosis. Leprosy is not very uncommon these days. Present with anterior uveitis with lepra nodules. Again, post-cataract surgery, P. acne endophthalmitis can present as anterior uveitis with these deposits on the PC. Again anterior uveitis, posteriorly retinoblastoma. CML can present as anterior uveitis again. Look for complications also. Thank you.
Thank you, Dr. Risha, for that excellent presentation on the wide spectrum of anterior uveitis infective etiology and giving us many valuable clinical tips. So now I invite Dr. Neetu Latif, uvea consultant at Giridhar Eye Institute, to talk about approach to infective posterior uveitis.
Yeah. So starting with the Sun classification of uveitis, posterior uveitis, when we call it posterior uveitis, when there's inflammation of the retina and the choroid. So it can be a retinitis, it can be a choroiditis, chorioretinitis or retinochoroiditis, neuroretinitis or retinal vasculitis. Now when you see a case of posterior uveitis, remember 4 R's. One is the clinical phenotype. So you can't confuse between a retinitis or a choroiditis, because retinitis points more towards infective etiology. The second is the reason, whether it is infectious or non-infectious. Third, is it real or is it masquerade? And fourth, is it a recurrence of the disease or a complication of the disease? Retinitis, as I told, there is more chance of being infectious. It can be focal. So when it comes to focal, the most commonest is Toxoplasma retinochoroiditis, and a non-infectious etiology is Behçet's, which is sometimes rare to see. And multifocal or diffuse, you have the viral retinitis and post-fever retinitis. Now, how do retinitis lesion look like? So when it is a full thickness or inner retinal involvement, you see a bright yellow fluffy lesion with indistinct border. So the retinal vasculature passing through these lesions appears obscured, and it may produce moderate to severe vitritis. Now when it is an outer retinal inflammatory lesions, it becomes a dull orange or yellow with indistinct borders. Vasculatures may remain clear over the lesions. Vitritis could be mild or moderate. So see this fundus photograph of this patient. There is a yellowish lesion, a retinitis lesion, which is a foveal threatening lesion. So as you see, zoom in, you can see that the lesions are fluffy yellow with indistinct border, and the vessel is, you can see the vessel is obscured over the lesion. And you see the OCT, there is a full thickness retinitis lesion, retina is involved, and the underlying choroid is not involved here, but the choroid is not appearing, it's not appearing properly because of the retinal involvement. This patient is diagnosed as Toxoplasma retinitis, and we give a intravitreal clindamycin and see the response to the treatment. Now, most of the time, Toxoplasma present as retinochoroiditis. So this is one patient who presented with retinochoroiditis. You see the OCT, there is a full thickness retinitis, underlying choroidal hyporeflectivity and choroidal thickening, and a localized posterior hyaloid detachment. And you can see these rounded bodies, which are typical of OCT finding in Toxoplasma retinochoroiditis. Also, toxo can present as satellite lesions. So what are satellite lesions? These are lesions where active toxo appears adjacent to a scarred lesion. So this is a patient with satellite lesion and frosted branch angiitis. Just look into the vessels of this patient. It is like 360-degree vascular sheathing. Now coming to the other etiology, post-fever retinitis. So post-fever retinitis is multifocal retinitis, and it is because of immune-mediated reaction to the pathogen, mostly a fever which has happened within 3 months. And as you can see, the retina, the OCT, there is a retinitis lesion here, and also the other eye, there is subretinal fluid, and you can see the hyperreflective dots in the vitreous, which are the features of post-fever retinitis. So identification of these clinical phenotypes is very important, because when you treat it appropriately, you get a better results. So this patient improved from 612 to 66 with oral steroids and doxycycline. Now this is another case, a 44-year-old man who came to us with a necrotizing lesion, a disc edema, a necrotizing lesion here, and multiple retinitis lesion, Some are along the vessel, some are distributed randomly. So we had a query whether it is toxo or retinitis. But toxo, we don't see these type of pointed retinitis lesions. So then I started on empirical antiviral for this patient, sent him for the blood reports, and this was the OCT picture where there's a full thickness retinal involvement. And within 3 days, there was a rapid deterioration. You can see now the lesions have become more confluent, and there is a peripheral involvement, a circumferential spread. So no doubt this is a case of ARN. And we started him on IV acyclovir, and then followed by oral steroids and oral antivirals, and see how beautifully the retina has responded to the treatment. Now, not always acute retinal necrosis present like that, but most of the time, when to suspect acute retinal necrosis. So when you see this type of anterior segment finding, where you see mutton fat, sudden onset, vision drop or pain, and mutton fat KPs, you definitely need to do a clear fundus examination. It's very difficult to do a fundus examination here because the vitreous is very hazy here, and we managed to take a photograph showing the acute retinal necrosis here. Coming to CMV retinitis, the Sun criteria classified CMV into wedge-shaped area of retinitis, hemorrhagic retinitis, and granular retinitis. So vitritis will be typically none to mild because mostly it occurs in immunocompromised patient. Now this is one of our patients with CMV retinitis in HIV. Here you can see the right eye. It shows a wedge-shaped appearance with the apex pointing towards the optic disc and massive hemorrhages over the retinitis lesion. So this is a wedge-shaped defect, which is otherwise known as the tomato ketchup or the pizza pie appearance. And the left eye, you can see the granular form of the CMV retinitis. And granular form usually affects the periphery of the retina, and it doesn't have much of hemorrhages. So this patient actually we treated with oral Valga and cyclovir, and he responded very well to treatment initially. But on follow-up, he had a recurrence of infection, as you can see in this picture. So we just worried whether it could be an immune recovery uveitis, and we extensively investigated again, and we came to know that we talked to the HIV specialist, and then we found that the patient is not receiving treatment for syphilis. He was syphilis positive. So then simultaneously we did treatment for syphilis, and see the OCT here, the retina is so thinned out because of the viral attack. And this is the final visit follow-up. And he's doing well with under control. And nowadays, I don't think CMV retinitis is more common in HIV. It is more common in SLE. And this is a patient with SLE with CMV retinitis, managed properly and doing well with treatment. Now, another entity is syphilitic retinitis. So the great mimicker, as you all know, it can have a varied presentation, but few are pathognomonic of syphilis. So that is a ground glass retinitis, along with these punctate precipitates, pre-retinal precipitates. So these are the pathognomonic of syphilitic retinitis. This one is a classic choroiditis. So to differentiate, these are multifocal choroiditis. As you can see, it is a deeper lesion, dull yellow color, and you can trace the vessels over it. And this is the FFA of this patient with early hypo and late hyperfluorescence. And this is actually the patient responding to oral steroids and ATT. Now, this is another patient with a granuloma and TB granuloma. So how will you differentiate it from sarcoid granuloma? So you see these hemorrhages over the granuloma because it has the TB granuloma is more VEGF driven. So it shows these hemorrhages changes. And also the OCT showing a contact sign as well as a choroidal granuloma with SRF. ASPPC. ASPPC is acute syphilitic posterior placoid chorioretinitis. So this is one of the patient who presented to us. So you see the fundus, nothing can be made out. We did a AF, and you can see this hyperfluorescent hyper lesion here. And you see the OCT, there were actually hyperreflective materials over the RPE. So we suspected syphilis, and his TPHA was positive, and he's doing well with treatment. Now, the next thing you have to think in mind is about the masquerade. So this is one of the 69-year-old lady who presented with dense vitritis, and you can see these yellow lesions in the periphery. It was not looking so good, and we could not properly put into any disease. So then we thought what to do next. So then we waited for 2 weeks, and then again did a VIT biopsy. And the VIT biopsy, histopathology, we didn't get anything, but the MYD88 gene was positive. Now, all that is yellow is not choroiditis or retinitis. See this picture, you see a yellow lesion here, and you see a dark spot here. So what is this? This is actually a multifocal CSR. So this dark spot indicates a site where the leak is there. So this is another patient with multifocal CSR with RPE tract. Now, whether it is a recurrent or a complication, so this was one of the patients who came to us who has received IVTA elsewhere, initially was diagnosed as toxoplasma. You can see a fulminant retinal necrosis. So you have to think before you inject. So definitely you should be aware of the diagnosis, and you should be clear about your diagnosis, and then only proceed with any sort of injections in the eye. So my take-home message is think infection first in any posterior uveitis with focal lesions, vitritis or necrosis. Missing it can be vision threatening. And history with pattern recognition guide you to diagnosis. Treat early and specifically. Monitor closely for complications and recurrence. And when in doubt, refer early. Thank you.
Good morning, everyone. So I'll be talking on multimodal imaging in uveitis, and there might be little repetition or overlap with some of the cases which has already been discussed previously. So does MMI actually makes a difference in uveitis? Yes, we have the evidence here. This is one of the largest studies in uveitis with more than 6,000 patients over a period of 30 years, and it was found that the percentage of patients with unidentified cause of uveitis decreased from 50% or 55% in the 90s to almost 25% by 2020. And this huge difference is due to many factors, of which an important is multimodal imaging involving OCT, ICGA, SDOCT, wide field imaging, which has really made a difference, EDI, OCT, which has given more depth, UBM, etc. So here I'll take you through some of our cases where the imaging really made a difference. So this is a 36-year-old man who came with a decrease in vision. Fundus just showed some vague RP changes, and the person who did a fields which showed central scotoma, and he was referred as retrobulbar neuritis. But the autofluorescence showed a classical hyperautofluorescent lesion with ellipsoid zone loss and outer retinal nodularity. So we suspected outer retinitis. He was positive for TPHA and VDRL. So this is a case of acute syphilitic posterior placoid retinitis, and this is one situation where multimodal imaging is a must for diagnosis. Many situations we do imaging more for documentation, but here it is absolutely necessary for diagnosis. I am showing you two retinitis lesions with their OCT, and both has full thickness retinitis, and we always have this confusion whether it is toxo or viral. In the first case, there is associated focal thickening of the choroid with hyporeflectivity and disruption of the choroidal architecture, adherent posterior hyaloid with dense vitritis, which definitely suggests this is toxoplasma, whereas in the second case, the choroid is relatively spared because this is a retinitis and not a retinochoroiditis, and there is retinal tissue loss with hyperreflective vertical strips suggestive of cavernous retinitis, as we see in viral retinitis. There are some more differences. In the toxo, we see this characteristic round deposits along the posterior hyaloid, which is usually not seen in viral, and hyperreflective deposits on the inner retinal surface in toxo, whereas there is more chance for IRF and SRF in viral. See, these are not 100%, but these are points which will help us to make a differentiation. Now this is another elderly 48-year-old lady who came with decrease in vision. She's a diabetic, not well controlled, and it looked like something like a large cotton wool spot or retinitis like lesions with hemorrhages and very significant macular edema bilaterally. So even DME was considered as a possibility. Another section we can see full thickness retinitis with inner retinal hyperreflectivity, pre-retinal and subretinal deposits. FFA showed blocked fluorescence corresponding to this lesion with hyperfluorescent margins. So then we had the doubt. So we asked for the history again. She had fever, but in dengue and leptospirosis was negative. Other uveitis workup also negative. So this is post-fever retinitis. And she responded well to treatment, but a repeat FFA showed inflammatory new vessels, which is very common in post-fever retinitis, so this is important. And she definitely improved with treatment, but somehow the vision in the right eye remained poor. And again, it is the imaging that helped us, which showed the significant cystoid edema with a VMT in the right eye. So imaging definitely has a role in during the entire follow-up of fever, post-fever retinitis. This is again another situation, an elderly patient with bilateral cataract, vitritis, and so the view is hazy, and again yellowish lesions which might make you think, is this a retinitis? But he is known KSOS lymphoma, and the typical lumpy bumpy appearance with thick sheets of retinitis will definitely give us a diagnosis of primary vitreoretinal lymphoma. So again, to distinguish masquerades, imaging is so important. Now I'm showing you two images with multiple yellowish lesions, not as bright yellow as the retinitis we saw. Here you can see a huge choroidal granuloma with SRF, and here the lesion is more lobulated, ill-defined and non-homogeneous, and with the contact sign there is no doubt this is TB granuloma. Whereas in this case there are multiple small granulomas which are more rounded with well-defined margins and homogeneous, which tells you this is more likely a sarcoid granuloma. So again, in choroidal granulomas also, the imaging will help us. Now this is a case of retinal vasculitis with hemorrhages, but it was FFA which documented not only the extent of inflammation, but also helped us to identify the extent of non-perfusion and NVE, and she was then subsequently diagnosed as occlusive retinal vasculitis due to TB. This is another patient who is on ATT, and when he came to us, he had this extensive vasculitis with hemorrhages, and as expected, FFA showed the areas of capillary non-perfusion, and we did laser for him. I thought that should be fine. But during the follow-up, you can see there are many skip areas as well as new areas of capillary non-perfusion on the nasal side, which helped us to plan the supplemental laser. One more patient of TB retinal vasculitis had a yellowish lesion inferiorly which looked quite elevated, and we could really make it out only with the help of the OCT. And again, FFA showed the capillary non-perfusion, NVE and the granuloma. So here we modified the treatment and gave an intravitreal anti-VEGF, and we can see the beautiful response post-injection. So extremely useful in retinal vasculitis, in the evaluation, in planning treatment and in follow-up. Again, I am showing you two lesions, active lesions adjacent to a scar. In the first case, it is suggestive of reactivation of toxoplasmic retinochoroiditis, whereas in the second case, we can see subretinal hyperreflective material with intraretinal and subretinal fluid, and octa showing a network showing that this is a case of secondary CNV with toxoplasmosis. So it is only with MMI you can differentiate between reactivation and a complication. This is a 7-year-old boy who was diagnosed to have macular scar and was just left without any intervention, but they came to us for an opinion, and surprisingly it showed an active CNV which was confirmed on OCT and octa. We had to give injection under GA, and he beautifully responded. So in these kind of situations also, there is no substitute for imaging. This is another patient with ARN, which Dr. Neetu has already shown, treated with intravenous, intraoral and antiviral and steroids. But then for aggressive management, we added intravitreal acyclovir also, and he responded very well. And we could really save him from the dreaded complication of retinal detachment. But 10 days later, he came back with complaints of decrease in vision, and you can see very extensive RP mottling, which we hardly see in a patient who resolved ARN. And this was highlighted much better in the autofluorescence. So then we had more doubt. OCT showed extensive hyper-reflective outer retinal deposits, extensive field loss on FFA. ERG showed gross reduction in the responses in the left eye, which I have shown in red boxes, compared to the right eye. MFERG also showed really reduced responses. So this was a case of retinal toxicity due to ganciclovir. And he is being followed up, and the lesions fortunately is improving. So in this kind of rare complications of treatment also, MMI has a valuable role. So advances in imaging has helped us to improve diagnosis and monitoring in infectious uveitis. Non-invasive modalities with high resolution images is helping us to see many details which we have never seen before. Each modality adds value in its unique way, so collective use is often needed, and judicious and cost-effective selection of the imaging modality is also important. Thank you, and I also acknowledge the help of my colleagues for the uveitic work.
Thank you, madam. That was a very informative talk. Our next speaker is Dr. Anuradha ma'am. Ma'am is head of the department UVA services, Aravind Eye Hospital, Coimbatore, and ma'am will be speaking on molecular diagnosis and medical management for infective uveitis.
Thank you, Dr. Neetu, and the Scientific Committee of Drishti 2025 for inviting me to talk on molecular diagnosis and medical management of infectious uveitis. When I think of diagnosis of infectious uveitis, I think of, it's something like trying to identify the culprit of a crime. So more often, you have to go by circumstantial evidence, by looking at the changes the organism has made in the eye or in the body, by either recognizing the clinical pattern or by imaging or serology. But ideally, if you want a definitive diagnosis, you should be able to isolate the organism either by smear or culture from the tissue. Now, you know that the sensitivity and specificity of these two tests is rather poor. And many of the organisms which cause uveitis, like viral and toxo, it's not very easy to culture it. So then the next best thing is to identify the genetic material of the organism in the tissue by means of molecular diagnosis. So I just want to go through the types of molecular diagnosis that are available to us. The oldest of which is the polymerase chain reaction, or the PCR, which is very much currently in use. So what it does is it's able to identify the genetic material, whether it's DNA or RNA, which is very specific to the organism, and it's able to amplify it, million times, so that from a small amount of the ocular fluid or the ocular tissue, you are able to identify the organism. Now, there's a new kid on the block. It is called the CRISPR-Cas diagnostics. So basically, this is a technique that was used for gene editing, and what it does is, it's able to really pinpoint a particular part of the DNA using a guide RNA, and using Cas9 or Cas12 scissors, it's able to snip it, very precisely. Now, how is it better than the PCR? It's far more sensitive, far more specific, and its turnaround time is something like 1 to 2 hours. Also, unlike the PCR, which needs a very sophisticated lab setup, this one in future might be able to give you bedside diagnosis, within a matter of couple of hours at a lower cost. So this has already been tested out in fungal end-off and in fungal keratitis. Now, the very important limitation of these two techniques is that, before you order the test, you have to have a fair idea of the suspects. You have to name them, you have to have a differential diagnosis. So when that happens, you will be missing out on something you didn't suspect clinically, or you will not be able to identify a new pathogen which could potentially cause uveitis. So there's something called metagenomic next generation sequencing, which is able to pick up all the genetic material in a given sample. So including that of the host DNA. And this, you eliminate the human read, and you compare it with a genome database. And it's able to identify up to the species level. Now, this might sound, very exciting, but the cost of setting up this is, really, really high because of the large amount of reagents needed and the complex equipment and the need for data crunching. So with that, let's move on to the medical management of the most commonly seen infectious uveitis, starting with the anterior uveitis. The most common ones is the HSV or the VSV anterior uveitis. And usually you don't need an AC tab for this because clinical diagnosis is enough. And I hope it has not been covered already and it's not a repetition. So if you see a unilateral recurrent anterior uveitis with corneal involvement, iris atrophy, and often associated with a raised IOP secondary to trabeculitis, you kind of know it is viral. If you don't have these typical features, you can go for an AC tab and send it for multiplex PCR. And your treatment consists of mainly systemic antivirals, and we give Valsivir 2 grams to 3 grams per day for 10 to 14 days. And to control the concomitant inflammation, you have to use Predford, which is a preferred steroid. And if there is an active corneal involvement, you can add on the topical antiviral treatment. For recurrent or chronic cases, you have to keep them on maintenance therapy with Valsivir 500 OD to BD for anything up to 1 year, sometimes even longer. So unlike the herpetic anterior uveitis, CME anterior uveitis is more difficult to diagnose clinically, even though they're supposed to have these coin-shaped KPs and nodular endothelial lesions. So the AC tab for PCR is indicated more commonly in CME anterior uveitis. The treatment usually consists of ganciclovir gel, which is given 5 to 6 times per day for up to 4 weeks. If the uveitis is very severe, atypical or prolonged, you add oral valganciclovir, which is 900 milligram BD for 2 to 3 weeks, and then taper down to 450 milligram BD. Along with this, like with other herpetic, you have to add Predford to control the concomitant inflammation. I think the infectious posterior uveitis has already been extensively covered. Let's look at the treatment for ocular toxoplasmosis, which can present as either a de novo unifocal retinitis or as a reactivation, like in this case. So you have systemic treatment and you have intravitreal treatment. The intravitreal treatment is now gaining a lot of popularity. But the mainstay of the treatment is systemic, usually with Bactrim, clindamycin or azithromycin. This may be supplement or sometimes even replaced as first-line therapy with intravitreal clindamycin with or without dexamethasone in cases where you have severe retinitis, vision-threatening retinitis, or where systemic therapy is contraindicated or not tolerated. So I want to share my first case, and this looks like a repetition actually. This is the third case being presented in the UVA session in this KSOS. There's a 49-year-old female treated elsewhere for floaters and decreased vision in the left eye. She has received oral steroids and 2 doses of IVTA. So at presentation, you can see the view is very hazy because of the IVT and the vitritis, but even through that haze, we could see very extensive retinitis. So she was sent for media clearing vitrectomy with vitreous biopsy and PCR of the vitreous sample. And POD1, you can see the very extensive retinitis involving all quadrants, and the tab turned positive for toxoplasma. So this is an atypical toxoplasma because of localized immunosuppression from the IVTA. And she was treated with a combination of Bactrim with intravitreal clindamycin and dexamethasone, and you can see the response. Again, when you have the typical presentation of herpetic viral retinitis, diagnosis and treatment is very straightforward, which is injection acyclovir 10 to 15 milligram per kilogram body weight given 8 hourly as a slow infusion for 7 to 14 days, followed by maintenance, which could be with valacyclovir or acyclovir. We generally give Valsivir 1 gram TDS for minimum of 3 months. In the active phase of ARN, we also like to give injection ganciclovir 2 milligram as an adjunct treatment because the combined therapy is supposed to have better results. We should not forget the role of steroids in ARN because they typically have significant vitritis, vasculitis, and sometimes optic neuropathy. And you should use adequate amounts of systemic steroids under cover of the antiviral. Now, this is my second case, which is a 13-year-old girl presenting with a sudden onset, rapidly progressing loss of vision in the right eye. You can see the necrotizing retinitis in the right eye. There's vasculitis, and you have these multiple retinitis lesions throughout the fundus. and the left eye is showing a early retinitis involving the macula. Now this presentation, didn't quite fit in with any of the known patterns of viral or toxo. So we knew that we were looking at trouble. So straight away she was sent for a vitreous biopsy of the right eye along with the baseline workup. We also considered the possibility of SSPE, subacute sclerosing parencephalitis. Now she turned out to be HIV positive, and the TAP turned out to be positive for HSV1 and negative for all the other organisms. She was treated with IV acyclovir followed by oral valsiclovir, and you can see the response to treatment. The classic CME patterns have already been discussed. Now, the one thing you should remember is that a CMV retinitis patient is immunocompromised until otherwise proven. So the two main arms of treatment is, one is identifying the risk factors and improving the immune status, which could be HIV, could be iatrogenic immunosuppression, or a malignancy. So you have to take care of that. The second line is, the second part of the arm is treating the infection, which again you got to remember that it's not limited to the eye. CME retinitis usually means there is, in an immunocompromised patient means there's infection elsewhere in the body. So ideally you should treat it with tablet valganciclovir, 900 milligram BD given for 3 weeks, and then reduced to 900 milligram OD until the lesions resolve and the immune system recovers. Okay? And you can supplement this with local therapy. Local therapy is not to be used on its own because it doesn't protect the other eye if only one eye is involved, and it doesn't clear the systemic infection. Again, the preferred agent is ganciclovir, 2 milligram. You can give it once or twice a week, and then on a weekly basis as maintenance until the infection resolves. Again, ocular TB has been discussed in detail. Now, the main line of treatment is ATT, 4 drug. We use 4 drug for 2 months, and then we give 2 drug for the remaining period. Minimum is 6 months. Some people use up to 9 months. Whether you should use systemic steroids in TB or not, that is still debated. Some cases, you might just get away with giving ATT alone. And if it's a vascularized lesion, granuloma, you can give intravitreal anti-VEGF. Certain cases, there are case reports of intravitreal moxifloxacin being used, to speed up the resolution of the granuloma. In case of inflammation which is not responding to steroids, so you get paradoxical worsening, we have even tried intravitreal steroids under ATT cover. So this is a HIV positive patient who is a defaulter, Manto negative, HRCT normal. The media is very hazy, and all you can see is these yellowish lesion. You don't even know whether it's retinitis or choroiditis. So these cases, you have to go for an early TAP. And this one, I thought it's a retinitis, but this one turned out to be positive for TB. So the molecular diagnosis, may not be required when the lesions are typical and response to treatment. But in case of atypical presentation, hazy media, unreliable serology, which is often the case with an immunocompromised patient, poor response to treatment or recurrence, you will have to go for molecular diagnosis. And a lot of new techniques are on the way. Thank you.
Thank you so much, madam. Thank you so much for that elaborate talk on management of infective uveitis. Now I would like to invite Mahesh sir. Mahesh sir needs no introduction. Sir is the head of the department Retina Girdhara Institute and president KSOS.
Immediate past president.
Yes, immediate past president KSOS. So we'll be talking on surgical management of infective uveitis.
The biggest problem in uveitis is we have to give steroids. We are not sure whether it's infective. So I will give one clue. If you want to rule out TB and you are sending to pulmonologist, if the MANDU is positive, so they will say there is no evidence of tuberculosis because they will do some tests. So don't write that like that. he is having a choroiditis, we are going to give high dose steroid. Kindly advise regarding fitness since his MANDU is positive. Just write like that. Then they will probably properly treat. This is one technique. You can all practice this. Otherwise, you see, they will do, there is MANDU positive, other things are negative, no need of steroid. So this is the best method. So that is, okay. So this is surgical management. I don't have much of experience, but because our uveitis department is managing very well. The diagnostic surgical procedures are aqueous tap or vitreous tap. Both are used. Aqueous tap is very easy. You can do easily. Vitreous tap is mostly needed. The tolerance to tap is very less now. Immediately uveitis comes, we want diagnosis. Initially what we used to 25 years back, we will give steroid, then we will wait. If it is ultimately when it is getting bad, then only we will think about all this tap and all this stuff. And now the molecular diagnostic PCR, everything is available everywhere. So that has improved the results and the need for vitreous tap. So the second indication for surgical management is therapeutic indication to manage complications, to clear the vitreous debris after the things are gone. Then the most important thing that I come across is RD in acute retinal necrosis. So there are other surgical treatment needed if there is a complicated cataract or secondary glaucoma, which I am not going to cover. So this is a case, 64-year-old came with a hemorrhage in the macula. It looks like a CNVM, and Avastin was given based on this OCT picture. There is a strum in the central area, subretinal hyperreflective material. It was thought that it was a classic CNVM. 1 week after injection, it has become like this. There is an abscess there. So it is not due to the Avastin that has resulted. It is a misdiagnosed one. The initial picture, it was looking very harmless thing. So it was a abscess in 1 week, and we did all investigation. Vitritis was there. We did systemic investigations, and then vitreous biopsy was done. So vitreous biopsy is a simple procedure. You can do it single port with 23 gauge. You don't even need that suturing. So here this is a old picture. Again, yeah, it is not working. So important thing is, once you start aspirating with cutter and suction, before you remove the cutter outside, you have to clamp the tubing. Otherwise, this fluid, whatever you have aspirated little, will go to the tubing and you will not get any sample. Another thing is, if you are going to do a proper vitrectomy also, if the vitreous is very hazy, you are going to do a proper vitrectomy, you can have 3 port. With in 1 port you can switch on air so that fluid is not mixing. Under air you can do little vitrectomy and then switch on the infusion. So this is a simple procedure, and we are getting lot of positive results. This patient which I showed had excitone was positive for TB, and patient had incomplete treatment long time back, started on steroid. This case we lost. In spite of all these things, it became phthisis. So that is so this case I wanted to show just because to show the importance of vitreous tap. Now acute retinal necrosis is the most difficult surgical treatment. Why it is difficult is there will be multiple breaks, sieve-like break across the retina. There will be severe fibrosis after laser. When it heals, it will be totally fibrosed, a lot of membranes over the retina, and many times you can get hypotonia also. So this used to be one of the indications for high density silicone oil, which we cannot remove for a long time. So this is a case which I operated. Patient had acute retinal necrosis and it healed, and after 3 or 4 months, patient had RD involving the macula. The lower part you can see that whole area, atrophic area, it has multiple small holes, and it detached, including macula was detached. So the most difficult problem here is to induce PVD. there will be nothing. Actually, a struggle for half an hour and put the triamcinolone on and then try to peel it. I made couple of breaks and with the forceps somehow managed PVD in at least in the other areas and shaved the vitreous and put silicone oil. So this is a very difficult surgery. Whichever case, this case underwent the oil removal later, but many times we will not be able to remove the oil because of the hypotony and fibrosis. It will redetach again. So this is just shaving all other areas. By the time PVD was induced, it had become bullous. So extremely difficult PVD induction. So this is some points that I thought I can share, and then after silicone oil. Okay. So this is the usual standard treatment for AR and retinal detachment. We use 5000 centistoke oil, which emulsifies less, and we can keep it for a longer time. Then I thought one more patient I can share. This was a patient with defective vision, and OCT revealed loss of ellipsoid line in the left eye, and all the areas had ellipsoid disruption, and this was the fundus autofluorescence, plenty of pigment disturbances, and this was the angio with multiple leaking areas, and in one of the sections you could see a small worm in that area. So this is another thing that we can, so this is a worm in that area which was moving around. Laser was given. Once you start laser, it started moving. So I went back behind the worm and then gave laser. That is the worm going that way, and then ultimately killed this thing. So this was the, so this is laser, but sometimes you can get it follow-up OCT. There was recovery of the ellipsoid line, but vision was not improving beyond 6/60. So this is follow-up. So this is another case which was treated that the design is not because that I made it, because it was moving around. Okay. So and sometimes you get it into the vitreous cavity. This is a dead worm. Then I could not get my video. Sometimes you have to go inside and remove the vitreous along with the worm. So this is another this thing. The last part is endogenous endophthalmitis. We get not many. Some people get lot of endogenous endophthalmitis. This was a patient on dialysis for diabetic nephropathy, sudden onset of defective vision. So granulomatous uveitis, cells in front, behind, and patient. This is the B scan. Already bad. Patient was very sick. So intravitreal voriconazole was given based on the central line culture which grew candida. This luckily we could save this eye with the systemic and oral treatment. So nowadays for endogenous endophthalmitis also it is little aggressive. Immediately do vitrectomy and diagnostic test for vitreous cavity. So these are some of the surgical indications for infective uveitis. Thank you very much.
Thank you so much, sir. Any questions from audience are invited. Any questions?
You can discuss.
Okay, so, I would like to request my sir to present the memento to Anuradha madam. So with this, thank you all for your patient listening, and thank you once again, and we'll wind up the session.